Rose is good.
You good?
She's good.
Okay. So we'll call the meeting to order, Economic and Tourism Development Commission. And I'll ask for approval of the minutes. I guess a motion in a second to approve the minutes from April 9th.
So moved.
Second? Second. Any discussion? All in favor? Aye.
Aye.
Any opposed? None. So thank you. And so Chairman's report. We unfortunately had Dick Story resign due to his personal issues. And so we are fortunate enough to have Bob Jacob appointed in his stead to fill his unexpired term. So welcome.
Thank you.
Mr. Jacob. And I don't have anything else to report other than to highlight a couple things in your report, at least that O'Connor's was purchased.
Yes, yes.
That's good. You know,
Great news.
any plans for that? We don't know at this
Don't know
point.
any plans yet.
Okay.
But Naya bought it.
Cope bought it.
Well, yeah, but Naya's gonna run it, his picture.
That's what I
just like-
understand.
Yeah,
Yeah.
yeah, and he's gonna keep it like it is, it's gonna keep it like O'Connor's was. TVs and sort of a college hangout kind of
Okay.
thing. Rent the upstairs apartment,
Nice. Okay.
keep the swimming pool even.
Very good. So and without anything else to report, I think we'll go right to our speaker. We have today Zach Royston, Vice President of Rural Healthcare Transformation, Executive Director of Shore Medical Center at Chestertown. Thanks for joining us.
Well, thank you very much to the Commission for having me out today. And I'll start. This is National Healthcare Heroes Week. So if you see a healthcare provider in the community, thank them for what they do and for the service that they provide. You know, this is as with many industries, healthcare is ever growing in its challenges. And, you know, we've seen some of the impact of that in our local community and across the Shore region. I'd also like to thank the Commission because this was one of the first meetings I attended when I joined Shore Regional back in August as the VP of Rural Health, and was graciously welcomed by Jamie and Dick and Judy and others and Paula. And from there have started to create, I think, some good roots in the community. My wife and I moved to Chestertown in November after I started the role in August. And just delighted to be here, a part of this community, having been originally from Cecil County, which I know we can debate whether that is or isn't part of the Eastern Shore. So we'll save that for another meeting. What Jamie had asked me to do today is come and spend a few minutes with you and sort of updating the Commission on what's going on with healthcare here in Kent County, a little bit about what is happening with our new regional medical center, which is being built in Easton. And then I'll just share a little bit about the sort of the climate that healthcare is facing, as so many other industries are facing, and where I see some opportunities for greater partnerships. And I think that really is the message of healthcare today, is around partnerships. I did provide packets to the Commission, and there are available packets for anyone else in attendance. To just share some of the highlights and the services. As I've been in and around in the community over the last 9 months, a big part of the role that I serve is trying to get in with local community organizations. Jamie's had me over to the Rotary, up into the Lions Club, Chester Valley Ministers Association, and a few other public gatherings, and really speaking to and trying to pivot the thinking around and moving from a constraint and closure mentality in the community around, in particular, services here at Shore Medical Center at Chestertown, to more of thinking in terms of where we have the opportunity to be vibrant and thriving in our healthcare delivery within the constraints that exist with healthcare in general. And so, you know, that's a first opportunity, I think, for members of the Commission. You know, I recognize that healthcare is a cornerstone of economic development. Being able to say that you have a hospital with services, you know, a functioning emergency department, inpatient unit, surgical services, medical specialties, you know, can sway individuals in making business decisions or personal decisions about where they reside. And so I'm here today to reiterate the commitment that University of Maryland Medical System has, Shore Regional Health has to maintaining a thriving and growing healthcare footprint within Kent and Northern Queen Anne's County. So please hear that first and foremost. And my ask of the commission members would be to help me as ambassadors in that message within the community, recognizing that isn't necessarily how everyone may perceive our services and our availability. So I'm opening myself up to being able to meet with any organization, individuals who are interested in hearing more about what we are doing, what we will be doing to further perpetuate that positive and growing image of healthcare for the citizens of Kent and Northern Queen Anne's County. In terms of the scope and the magnitude, I think it's important to recognize that as a part of the University of Maryland medical system, we wake up every day thinking about Marylanders and serving Marylanders. Our health system does not venture outside the boundaries of the state of Maryland, unlike several other health systems. So we really do try to put Marylanders at the forefront of our decision making and our thoughts. And with that, Shore Regional Health encompasses the 5 counties of the Mid-Shore. We cover about 2,000 square miles, which houses a population of about 175,000 people. And the way we share that with our team members and others is, we're roughly about 200 square miles smaller than the state of Delaware, and we serve about 1 million less people. So the geographic challenges that are faced in rural communities are real, and they continue to be one of the biggest areas of opportunity that we see. And how do we expand and go beyond the expectation that individuals have to come to us for services, but instead, how do we build programs that allow us to go into the community where people are, work, live, and play, and be able to deliver services there. So we've got some fledgling programs that are supporting that, but we're looking to grow our telemedicine capabilities. Our Shore Community Outreach Team, which has been recognized with several awards in the state, they go out into the community and are working with individuals in their homes to try to bring appropriate health care and support services to them. And we also have a very vibrant community nurse educator who delivers free training to individuals who CPR, caregiver classes. We're doing a safe sitter class for teenagers if they want to become babysitters so that they can be effective and safe in that. And that's some of the sort of non-traditional programming that you'll see reflected in the documents in the folder that are beyond the traditional thinking of what does a hospital do. Because the hospital and what hospitals do is take care of people when they're in distress and they have the greatest need. What we want to do is position ourselves as a health system where we're thinking beyond the hospital walls, but we're actually growing and building the healthcare capabilities and try to keep people well and healthy versus relying on, when things have gone bad, fixing the problem, right? And that requires partnerships, and that is a part of what I mentioned earlier about the opportunities. So beyond the geographic challenges that we have, there are economic realities that all healthcare systems face. Maryland has a unique healthcare reimbursement model compared to the other 49 states. And with that comes some very positives, but also some unique challenges. And, we need to operate and we need to provide the services that we can do effectively and safely. And that led to some very difficult decisions, about a decade ago around what does it really mean to deliver rural health care, which led to the formation of Maryland's first rurally designated hospital here in Chestertown, which reduced the footprint of services. OB is the one that I typically get the most questions about. But able to maintain, again, emergency department services, medical, surgical, inpatient care in a critical access sort of oriented model, and essentially same day or 23-hour surgical services. And the reason that we're able to do that is because we are a part of this bigger hub and spoke model with the University of Maryland medical system. So we can anchor the healthcare services for the northern part of our service area here in Kent County, Western Carolina, Northern Queen Anne's County. But then recognizing that when there are patients who need services beyond what we can deliver here in Chestertown, we can then refer to tertiary care in our community hospital in Easton, which can offer cardiac coverage, enhanced stroke coverage, as well as advanced musculoskeletal cancer care and other specialty services that just from an affordability, from an efficiency, and primarily from a safety standpoint, we couldn't do here in Chestertown in a reasonable manner. And then beyond that, Shore Regional Health benefits from being a part of the broader University of Maryland medical system, where we can tap into the quaternary and academic medicine capabilities of the medical center in downtown Baltimore, with shock trauma as the preeminent trauma service in the world, and then their vast array of other advanced medical care procedures. And I think that's something that a lot of rural communities don't benefit from, and we see that show up in the challenges and the limitations or the reductions in services which continue to hit the headlines with rural communities. Beyond that systemization of healthcare for Marylanders, and in particular for the Eastern Shore with Shore Regional Health, we look at the exciting new project on Route 50. I don't know if anybody's been down that way. We broke ground officially in July on the new regional medical center. From an economic development standpoint, Bramble was our selected contractor for all of the site work that's happening there. So that's leading right back into the economic vitality here in Kent County. And they've done a tremendous job of helping us to maintain and keep on schedule with the site work. The big first milestone, which we had tagged, was in order to build the new hospital, we had to reroute Route 662, which was not necessarily a welcome conversation within Talbot County, and for individuals who traverse that route to either get to the beach or avoid the beach traffic on Route 50. But literally a corner of the hospital is actually, foundation is going to be where the previous 662 ran. So that has essentially been rerouted. We had Memorial Day targeted as the reopening of 662. Knock on wood, it will be reopened by the end of the week. And individuals will be able to take advantage of that before the beach season is upon us here in the next couple of weeks. Foundation will begin being poured within the next 2 weeks, and we should see vertical steel happening by the fall timeline. So we are on target to open the new regional medical center in July of 2028. That will bring us from the current 17-acre campus in downtown Easton to our 430-acre campus there between the community center and the airport, and give us a lot more opportunity to continue to expand and build sort of a centralized healthcare delivery facility, starting with the existing services of Shore Medical Center in Easton, as well as some of our hospital-based outpatient services. So that'll be what's located there initially, and there'll be a 6-story hospital tower and then a 2-story medical services building as a part of that. The total number of rooms that building will have will go up slightly by about 25. And part of that is controlled by the Maryland Healthcare Commission, and they actually, through certificate of need, determine how many beds a hospital can have. So that was a passionate conversation back and forth with them by the individuals who are involved. But this will be a brand new state-of-the-art facility there to serve the Midshore healthcare delivery needs for now and into the future. Here more locally in Chestertown, we continue to invest in the services at the Shore Medical Center of Chestertown. Some of you may have seen the article from October where we commissioned 2 new Roche lab analyzers to bring us into the current state of standard of care for laboratory services. It also fits into our journey of high reliability, where Dr. Santa, our system CEO, wants the University of Maryland medical system to be the safest healthcare system in the state within 5 years. Part of the way we get there is by trying to standardize and align all of our equipment and resources so that team members, when they're servicing multiple centers, they're able to sort of easily transfer and operate without necessarily having to learn new skills to simply perform their routine roles. The exciting project right now is we are in the midst of an installation of a brand new MRI machine here in Chestertown. So the Chester River Hospital Foundation donated the funds for us to replace a 20-plus-year-old MRI. The new MRI will be the most state-of-the-art MRI on the Eastern Shore. And through the donations of the Pink Polar Bear golf tournament, we're going to be able to add a breast coil onto that MRI, which will allow us to expand our ability to do MRI breast imaging, which is important for anyone who may have high-density breast tissue. Mammograms aren't always capable of picking up, the fine details of early-stage cancers, but the MRI is the standard of care for that next level of diagnostics for those patients, and so we'll be able to do that here in Chestertown. That work should finish up here in the early or late summer, early fall. And then we continue to work on, the general facility appearance, updates, capital improvements to modernize the facility from an aesthetic and make it more welcoming. One of my big pet peeves there is our signage and wayfinding is still challenging for a lot of individuals, so we've got some work to do there, and just making it more inviting and welcoming to individuals as we've reduced the number of services, the number of people that are in the hallways. Some areas can feel a little bit empty, so we want to continue to improve upon that. Also, as we think about the Shore Medical Center of Chestertown and its role as a rural healthcare in a community that is seeing an aging population, part of our rural healthcare designation was to look at and enhance our capabilities around supporting individuals who are 65 and older. So we are the Institute for Healthcare Improvement age-friendly designated. So we've implemented additional steps for patients on our inpatient unit who are greater than 65 around what are known as the 4 M's. So this is first starting with asking the individual what matters most to them. That isn't something that always happens in healthcare, which you would think would be a routine question for folks. And that isn't necessarily, I want to get out of the hospital. It really is, I want to be able to get to my grandchild's soccer game on Saturday. And it's really finding those things that are going to be motivating and inspiring to that individual to partner with the healthcare providers and team members to advance their own healing process. The other 3 areas that the 4 M's cover are medication reconciliation and management. Medication issues are one of the biggest threats to the aging population because of individuals having multiple medications or polypharmacy, or their medications not being looked at in terms of compatibility or even duplication of the same medication or same types of medication. So we look at that very thoroughly with a pharmacist for each of those patients. Mentation, so we do a lot to screen individuals for cognitive function and make sure that there aren't any underlying medical conditions that may be showing up as cognitive. So you may or may not be aware, but individuals with urinary tract infections can often display outbursts and very significant behavioral challenges, which could come across as violence or just being that type of person, but really there's an underlying medical concern to that, and so really taking the time to make sure we're digging into any of those issues. And then last is mobility. So a big part of healthy aging is maintaining mobility. So we have our physical therapist, Bruce and Joanna, who have their own physical therapy around the corner. They're our on-site physical therapy team. They're working with patients and screening every patient for how quickly can we get individuals mobile again, because that's a big part of the healing process. In addition, our emergency department and 2 others, we're working on our 4th emergency department to get certified, is recognized by the American College of Emergency Physicians as a geriatric accredited emergency department. So again, we've taken additional steps to recognize the differential support that individuals who are aging may need beyond other patients coming in. And a good example there is often when individuals come into the emergency department, they're placed in an NPO or nothing by mouth status because they might need diagnostic studies. And our goal is to limit that as much as possible because nutrition is paramount to the healing process for the aging and making sure they don't become malnourished, have their glucose levels drop, and those types of things. And then in 2024, Becker's Healthcare, which is one of the leading healthcare organizations in the country, recognized Shore Medical Center in Chestertown as one of the top 100 community hospitals in the country. So, we've received sort of national recognition for these efforts that we've put in place locally to support the broader community, but in particular our aging population that we serve here in northern Queen Anne's County. Any questions about any of that? And then I can talk a little bit about yeah, go ahead.
Missed one of the M's.
Medications, mentation, mobility, and then what matters most?
Mentation?
Mentation, yeah.
I'm sorry, I missed what that means.
So that's the screening for any cognitive or, altered mental status or those types of things. Yeah. Thank you for that question, Jane.
Question about the Easton office or Easton facility where the hospital is going to be. What happens to, are some of the services that are located down off of Idlewild, are those going to move to that facility as well? And then what happens to those buildings?
So we'll start with the current Memorial Hospital of Easton. So we've retained CBRE, and that is actually out to bid now to identify a purchaser for that building and that campus. Our medical practices over on Idlewild, Cadmus, and some of the other areas will remain where they are for now. There might be some services that come over to the medical specialty building, but this isn't a consolidation of all services at one time. Part of that is economically driven by existing lease or contracts and those types of things, but that is a part of the plan, is to look at how do we continue to bring services into a centralized location to make it easier for patients to navigate multiple specialties during one visit, those types of things. Yeah.
In looking at the sheet, the certificate of need approved beds, what stuck out to me is the one pediatric bed, and I don't know what that means. Does that mean, transfer out children that need inpatient care or what, just?
No, it's a great question. And so what we look at here is our pediatric population that we serve on an inpatient basis is typically a census of less than one a day. Right now we have 2 pediatric beds. And part of the way we're able to manage that is our mother and baby or our birthing center also can support pediatric patients. So these pediatric beds are really for individuals who may need special isolation precautions and have to be separated from newborns or others in our mother and baby unit. So, a child who has the RSV virus that needs to, we don't want them commingled with somebody, a newborn. We do have dedicated space to separate them from others.
Okay, thanks.
I have a question about the wellness program. So I think that's great, but have you set benchmarks? How will you know we're making improvement in that area?
So when you say the wellness
You talked about you were working with the community to set benchmarks for wellness issues. And
Yeah,
I just wonder how you're going to measure if we're succeeding.
Yeah, there's a national organization called County Health Rankings. They publish annually data on the health of every community by county level. And so we have the opportunity over a long term to sort of track and monitor some of that. More at the local level, or at the sort of more time boxed, we look at things like vaccination rates. We look at, number of individuals who are pre-diabetic and whether or not they're enrolled in diabetic prevention programs, either through the area health education center that's located down in Cambridge, but offers services throughout all 5 counties, or the YMCA. The challenge is with health and wellness, that is over a lifetime, and so you have to sort of pick these surrogate moments that represent what you hope is happening over a continuum. And diabetes, congestive heart failure, heart and vascular disease are the ones that we tend to anchor on in looking at are our programming interventions making a difference over a short term, and then hopefully that'll translate into a longer term health and wellness success.
Great, and so are we the only rural designated hospital? It says we were the first. Are there others?
We are the first and only.
Okay. Just wondered about that, how special we really are. And then, so with all the talks lately about cutting Medicaid, how dependent is the system on Medicaid enrollment, and how vulnerable are we to cuts? What are you anticipating, and what kind of resiliency do we have?
Yes, so, there are a lot of headwinds that are facing Maryland healthcare. Medicaid, potential Medicaid cuts are certainly one of those. When we look at here in at the Shore Medical Center of Chestertown, in 2024, about 7.9% of our patients served were Medicaid. Tracking annualized for FY 2025, we're up closer to 13% of our population here served as being Medicaid. So Medicaid cuts would have a disproportionate impact on this community, because then if there isn't support to enroll them in some other healthcare program, then they would essentially fall into the uninsured or self-insured category. And then part of the consequences of that is what we've seen is, instead of being able to have access to preventative health and wellness services, individuals either then delay care and it becomes emergency department or urgent care based services, or they delay to where they're even more catastrophic than that. And you're probably aware, one of Maryland's overall healthcare objectives is Maryland ranks typically, worst or next to worst in the country in terms of our emergency department throughput. So adding more pressure into the emergency departments, because that is now the access point for individuals without health insurance, will create broader ripples in our care delivery system. So the Medicaid cuts, Medicare is our #1 payer across Shore Regional Health. And so we're tracking Medicare changes as well. And then just, any grant or other funding that supports some of our health and wellness programs, certainly may result in us having to reduce what programming we can do. So our Shore Community Outreach team, our community health educator, has been fortunate to be able to be funded through some Maryland Department of Health grants for some of the work they've done, either the tobacco grant or disparities grant. And so, we're seeing where can we potentially pick that up, or where we may need to make, difficult choices around what stays or goes in our delivery. So, yeah.
I think Zach's comments kind of played into this little card as well, and it basically tells you like when emergency room or urgent care, so you kind of pick the right option, so not everybody is going to the emergency room for things that can be taken care of at urgent care. Because honestly, when urgent cares first came about, I was a little confused as to where to go first, so I thought this was really helpful.
And that's going to be one of the campaigns that we're going to have this year is, again, right place, right time, in expanding that also to include primary care and any telemedicine primary care capabilities that are available. One of the, I think we all recognize transportation is one of the biggest challenges that is faced across the Mid-Shore region. And that isn't necessarily just true for our patients, and I'll share a success with you. For us addressing our own ambulance transportation challenges at Shore Medical Center. So, patients who needed to be transferred from Chestertown to Easton or among the 4 emergency departments to one of the other 2 hospitals, we have to rely on a private ambulance service to do that. Across the Mid-Shore, there's really only one private ambulance service, whereas Charles County has access to 5 private ambulance services to move their patients. So our Chester River Foundation sponsored a pilot where we actually invested in a dedicated ambulance service here in Chestertown. So we have a dedicated ambulance posted at Chestertown. We are providing an investment in that because they don't do enough volume to cover their own cost, which is why they aren't here to begin with, right? Capitalism at work. What we have found is they were budgeted to about 105 transports a month. They're doing on average about 170. 70% of those transports originate from Chestertown. Quite a few of those are local transports from the hospital to, one of the skilled nursing facilities. A lot of those transports are from Chestertown to Easton. But then if they're in Easton and we're bringing somebody from Queen Anne's Emergency Department back to Chestertown, they'll sort of pick them up on the way. And what we found is in a 6-month time study, patients on average waiting for an ambulance in Chestertown was approximately 8 hours. So from the time that we identified they needed to be transferred to when we actually had a physical ambulance to do that was on average 8 hours.
That's with this one?
No, that was before.
Okay, thank you.
With the ambulance in place, it's down to 90 minutes. So again, our not insignificant but important investment in that service has a dramatic impact on getting folks to the right level of care as timely as possible versus waiting for services which may cause unintended consequences in their healing process. So again, another example where we're being thoughtful about our investments to support the broader Shore community. But that transportation is one that I know we continue to all wrestle with in terms of patients moving around, but it impacted us. And then heaven forbid the high winds and the Bay Bridge is closed, because then it's a whole different conversation. So we get pretty jammed up on those circumstances. So.
Zach, I have 2 questions.
Of course.
How does the total beds in the new Easton facility compare to the beds in the existing facility in Easton? And are you changing the bed count in Chestertown as a consequence of the new facility? And the second question relates more to, are you tracking the waiting time for people coming into the emergency room or otherwise who need a room and have to wait for it?
Yes, so thank you for those questions, Paula. In terms of the new hospital, overall it's about 25 additional beds compared to what the Memorial Hospital of Easton has currently. Now, with that being said, there are some important differentiations. So all of the rooms in the new hospital will be private rooms. So right now in Easton, we still have a lot of dual occupancy rooms. The other challenge, and one of our biggest barriers to moving patients into inpatient space, which sort of gets to your second question, is we only have about 30 rooms in Easton that are telemetry equipped. So that's the ability to do heart monitoring 24/7 on those patients outside of the ICU. So in the new hospital, all of the rooms will be telemetry equipped. So that will no longer be a barrier, and we will leverage centralized telemetry monitoring, so we're not having to stage a person on each unit, but they'll be in a command center where they'll be monitoring the full spectrum of patients on telemetry at that point. Your second question regarding boarders, yes, we track and we call the patients boarders. These are patients who need an inpatient bed, but there's no room at the inn, or there may be a room, but the room isn't appropriate for the level of care that they need, such as I just described with telemetry. We as members of the executive team get texts twice a day notifying us of how many boarders there are in the emergency department. We have a colors-coded escalation scale that goes from green to black. As we hit certain number of boarders, we implement different interventions to try to free up the capacity in order to get those individuals through and into the appropriate inpatient. That being said, this is a challenge that's being faced by, and in particular was being faced really in the previous 3 months in just about every healthcare organization in the Mid-Atlantic, with patients being held in the emergency department because there wasn't an appropriate inpatient bed. I was talking to a colleague, and she was in an emergency department in a large healthcare facility in northern Delaware, and they had 50 boarders in their emergency department just in the hallway, and that's where they were delivering care. So it's certainly not the circumstance that we want, and one that we work aggressively to try to get that number down as quickly as possible.
What is your average room occupancy rate right now?
So in Chestertown, we staff for 15 inpatient inpatient beds. Again, it's a med surge, so we can't take telemetry, we can't take advanced or more critical patients. Our average daily census is running about 6. We have been up to 15. We've increased our budgeted census in Chestertown because one of the things that we want to try to do is continue to leverage these beds in support of the broader network. We've had patients from Laurel at Cap Region come over to Chestertown because we had available beds and there was nothing on the Western Shore for them. We have patients coming up from Cambridge and Queenstown emergency departments to us. And so we try to level load with patient choice in mind, and that becomes a part of the conversation. Is even though there may be a bed available, an individual may wish to stay in the emergency department versus being taken that far away from their home community. So that's part of what we're working on and continue to try to improve.
And in Easton, in terms of average occupancy?
So I don't know those numbers quite as well. We typically run between 98 and 105 out of 120-ish rooms, so 90%. And again, it's really matching the patient need with the available room and recognizing the limitations there. Yeah.
So you said you staff for 15 rooms, and then most of the time there's 6, or?
In talking in terms of daily census can be a little bit confusing because that's the head count at midnight.
Yeah.
And it doesn't take into consideration the ebbs and flows. But essentially you can't staff for less than 15.
Right.
There's a minimum staffing level that's required. And so that's what we staff to, and then we try to pull those additional patients in to increase that. I mean, we've had 15 on the inpatient unit and 2 or 3 that we've supported in the emergency department. So, but that's sort of where we are now. Yeah.
But you don't have staff sitting around doing nothing.
No, and what we do is we flex up. So if we're gonna, and really this current staffing supports 12. If we're gonna go to 15, then we'll bring in that extra nurse to go to 15. But we flex up instead of having folks. The other unique thing here at Chestertown is we have quite a bit of our nursing staff that are cross-trained between both inpatient and the emergency department. So they'll flex between those 2 units to support the patient care delivery that's needed between those 2 areas. Yeah.
So just quick, what's your greatest concern, and what are you most excited about?
So I am most excited about, I'll start with that. I'm most excited about the early dialogues that I've had with individuals within not only Kent County, but Queen Anne's, Caroline, and that's really sort of the area I've spent the most time in terms of wanting to engage in partnerships and figuring out just really what is it that everyone's doing, what are we duplicating that somebody else could specialize in and free up some resources and capacity for someone else to focus on other things, and then where are those missed connections? And I think that it's interesting being in some of these conversations, and like Chester Valley Ministers Association, I was there and presenting, and we were talking about housing as a part of healthcare, and 2 individuals didn't realize they were sort of doing the same type of work, and so they were able to connect after the meeting and then sort of build off of that. So those connections and partnerships are the only way we're going to be able to have that infinite mindset of really delivering on the promise of healthcare in our communities. And that isn't going to happen because the hospital can do it, because the hospital, that isn't traditionally where the hospital has focused, right? The hospital's focused on taking care of people when they're sick, and we need to expand the thinking and the mindset. Mm-hmm. I think in terms of what keeps me up at night and and you know, it's sort of the worries is the ability to continue and build and grow capability and recognize that we need to move beyond hospital-based into what are the social determinants of health around housing, food, health equity matters, transportation as really the cornerstones of somebody's health status, and how do we sort of build that bridge to that conversation, because it isn't, again, what folks tend to think about when they think about healthcare delivery systems, and it's about, you know, mitigating those social determinants of health. And there's an interesting, the county health rankings, which I mentioned earlier, they've published and recognized that only really about 20% of somebody's overall health status is derived directly from the healthcare system. 80% of an individual's overall health is based on their personal behaviors and choices, which is a big factor, but it's also based on simply what zip code they live in and what are the environmental factors around housing, food, transportation, education that allow them to be able to be positioned to engage in healthy behaviors to then achieve a greater health and wellness standpoint. So, so I sort of flipped it as an opportunity.
Your last point ties totally into the way I like to look at economic development.
Yeah.
It's not just building the warehouse.
Right.
It's your community being healthy, prosperous,
Yep.
and economically well, so to speak.
Yeah, when I talk about, because my background and passion is around population health, and we talk about it being in terms of where people live, work, and play, and sort of recognizing that in all of those areas, that's where we have the opportunity to impact health. You don't impact health by sitting in an emergency department.
Right,
You might take care of your sickness, but we're not going to make you healthy.
right.
And that's a big part of the mission that I'm on to serve here at Truro Regional. And
Is
in our
that, in that
community.
regard, are there model relationships between hospitals and communities that you can look to as exemplars?
Absolutely, and we've, you know, started to form some of those. We have a great working relationship with like Chop Tank Health and the federally qualified health centers. And then, you know, there's work, and you may be familiar, it's called Collective Impact. And this is where you look at how do you create a convener organization with shared and aligned objectives. You put sort of the backbone in place, and then you let people be good at what they're good at, and not recognizing that, again, hospitals or others may not be the ones in the best position to lead that work, because we come in with a certain bias and a certain perception and don't necessarily recognize our own blind spots in those conversations. So there's a variety of models. Sarah from Chop Tank just brought in a new population health leader, and she has some of that background coming out of, it's either New Hampshire or Vermont, I can't recall, but we're having
New
conversations
Hampshire,
about how do we grow those circles of influence for our communities. Yep.
Before we move on, if it's okay, with Zach being new, I think 8 months.
Yep, 9 months.
About
9 months.
9
9
months.
months. 2 days ago.
Yeah, I mean, he's met several of us, and everybody wears 2 or 3 hats. So if everybody could introduce themselves and tell them like a little bit about your business, I think that would be helpful to him in making connections in the community and audience as well, if possible. So, Judy, do you mind starting?
I'm Judy Crow. We have a farm in Kennedyville. We make wine, grow grass-fed Angus beef, and have a bed and breakfast. And we farm.
Yeah, ditto, except for the wine and the breakfast. Well, we milk cows, so we have a Jersey farm in Kennedyville as well. We've been there since 96. My husband's a veterinarian, and I picked up your wife.
I was gonna say,
I
I
picked
know
up your
you-
wife at that Kent Cultural Alliance event where I was on the panel, and
Yeah.
we took her to the plant innovation meeting the other day. I had a great time.
Yeah. She wanted me to say hi.
Yeah.
So.
My name is Bob Jacob. I have a aerospace defense commercial machine shop on Mary Morris Road right outside Churchtown. We have about 21 employees. Most all of them live within Kent County.
Great. Do you do any work with over in Dover with, is it ILC or?
No, I'd love to do work for them.
Okay,
I
okay.
haven't got into, we are aerospace,
Connection?
we are,
I worked in Dover and we did a tour and I got, to play in the spacesuit and got spacesuit fabric and that kind of stuff, so that, yeah.
we are aerospace certified
Okay.
and military and all the other stuff.
Okay.
It's just, it's hard to get the connections being here in Kent County,
Yeah,
so.
great.
Hi, Charlie Athey, and work with Dixon Group.
Okay.
You're familiar with Kate
Yep,
Ray, I
yep.
think, yep.
Yep.
So manufacturing and real estate development.
Yeah, I called Jesse and said, hey, I could reach out to Kate and said, hey, Jesse, can you help me find a house?
Oh, so you're very familiar. Nice to meet you.
Hi, Zach, you and I have met and talked
Yes.
often.
Yeah.
We've talked several
Yes.
David Bowman, Chief Lending Officer with People's Bank.
Oh, great, thank you.
I'm Rose Osborne, and I'm with the Economic and Tourism Development Office on the admin.
Nice to meet you, Rose.
I'm Cheryl Golden, I'm the tourism manager, Jamie's office.
Okay,
And I'm Katie Abbott, I'm the Economic Development Manager.
great.
I'm John Price, a lifelong resident of the county,
Great.
former sheriff of the county,
Mm-hmm.
very familiar with the public safety aspects of our county, and I currently serve as a county commissioner. I do want to thank you for everything that you've done for our community. I would like to see some evaluation as we move forward with hopefully some housing for young people, and maybe some economic development will come in with that, because we've got to establish a good workforce here. I am a little concerned about the level of pediatric care that is available here locally. And I realize that you've studied it, and yes, Kent County is an aging community. I'll be 67 in July, so I can appreciate that, but I would hope that there would be a process in place where you would continue to evaluate the community's needs. And if pediatric reaches the level that I'm hoping it reaches, maybe you'll consider doing something in that particular area.
No, I appreciate that. So just two quick responses. So one is we do every 3 years community health needs assessment. We just wrap that up. So that helps us understand sort of what the community's perception of health is. But then we also do a medical staff development plan, and this is where we look at what does the current footprint of physician and advanced practice providers look like in comparison to what are the needs of the community who may be retiring. So maybe some positive news. We actually took over the took over the space for Dr. Ramirez's old practice over at Round Top, and we're going to be refreshing that and looking to recruit a pediatrician here to Kent, Northern Queen Anne's County to serve this community. We're also going to be looking to recruit an internal medicine and hopefully with a geriatrics background to join us at the Aging and Wellness Center here in Chestertown, in addition to our regular programming around trying to recruit primary care. We had been under a 3-year agreement with Chop Tank to not recruit primary care in Chestertown in order to help them build their Chop Tank office here. We are coming out of that and are now going to look to building our own additional primary care resources here. So hopefully that's moving in the right direction from what you're describing. Yeah, great.
Great.
Hi, I'm Christina Highland. I work with Tourism and Coldwell Banker Chesapeake, which is a real estate company. I do have a quick question for you.
Sure.
Are you able to tell us how many people were delivered in Easton from Kent County?
I don't have that number off the top of my head. I can look into that. I know we had, and if I have it, in the last 6 months, we had 5,500 ED visits, and within those ED visits, we had 2 deliveries that happened here in our emergency department. But the number of Kent County residents that were delivered in Easton, I'll have to look into and get back to you. So let me make sure I get your information and connect with you on that.
And so any information that you want to provide back, if you send
Okay.
it to me, I can send it out.
Send it to everybody, yeah.
Yeah, that's
and-
okay.
Yeah, and when the OB unit was closed, it was doing about 200 deliveries a year, which is, less than 1 a day, which comes at a fairly high cost for obstetrics coverage. But in addition to that, you think about it in terms of if you were having a knee replacement, do you want to go somewhere that's doing maybe 1 a day or 1 every other day, or do you want somebody who's doing 5 a day or maybe 10 a day, and creating that safety and quality curve as well. So
That's a
we're
little apples to oranges, but I get it.
right. But there is that need, and Dr. Webb and I have talked about that as well, and partnered on some of those conversations. So, but I'll certainly look into that and get back to you. Great. Anything else?
Thanks.
Thank you very much.
Thank you very much for your
Appreciate
time.
you being here.
Thank you.
And happy to come back anytime if you want any updates.
You're welcome anytime, as well as Jill. We would love to get her more
Everybody
involved.
loves Jill, not me.
Well, thank you.
So staff reports?
Yes. So we'll start with the 2025 meter primer for economic development in Maryland is scheduled for May 22nd. And it's from 9 to 3 o'clock. It's at DHCD in Lanham, Maryland. So Rose and Shallon are attending. Katie and I have something else scheduled that day. But if any commission members would like to attend, please let me know if you'd like to attend and you're able to attend. And we can cover the cost of that with interdepartmental budget. The Regional Revolving Loan Fund Focus Group, we are doing that on the 22nd. So it's going to be an either or, which one you can do, unfortunately. But we're doing a Regional Revolving Loan Fund Focus Group through the Upper Shore Regional Council. So the Upper Shore Regional Council is contracted with Bay Crossing to do this, so we're looking for people to join and give input. Where are the, I'm going to get this word wrong. Where are the gaps in funding for entrepreneurs or business startups? So that's what we're trying to determine, and then how to set that program up so that it would be the most beneficial and be a true revolving loan fund where the money comes back in and gets relent back out to additional businesses. So if anybody didn't get that information or needs me to resend it to them, I can do that.
That is all through the, it's all through the regional, it's not a county.
Correct. It's the Upper Shore Regional Council program, yes. And then Kent County is hosting the MDO meeting on June 6th at Crow Vineyard. And so that will be Rose and I covering for Shallon, because Shallon was awarded a scholarship to the Southeast Tourism Society's Marketing College. It's held annually at Mercer College in Macon, Georgia. So she'll be there from June 1st through the 6th. It's actually a 3-year program. The award is for years 1 and 2. Her scholarship's covered. And when she finishes 3 years, she will be a certified tourism marketing professional.
Well, congratulations.
So,
That's great.
yeah. And it was 2 on the Eastern Shore that were nominated to
It
go.
was offered to the MDMOs in the state of Maryland, and myself and Brianna Dix from Worcester County were both selected, so it's 2 Eastern Shore tourism DMOs that are going, yeah.
Kent Reserve Open House. Ribbon cutting is going to be held on May 28th. The ribbon cutting itself will be at 12:30. They start at 12, but the ribbon cutting will be at 12:30. And then I just wanted to mention there are brochures on the back table. There's quite a few. There's the new visitor's guide if anybody wants to pick up a few. But I also wanted to pass these out to you guys because these are mentors. So we're looking for mentors to be mentors to our business startups, entrepreneurs, similar to what our SCORE chapter used to be. So just something to consider, look it over. We have different brochures for mentees who are looking for a mentor, but this specifically is for recruiting of the mentors themselves.
There was a nice article in the paper on this.
Oh, good. I
Right?
missed
Didn't I
that
see
one, Judy.
I'm pretty sure they had that's
Yeah.
where I saw it.
Yep. I know that the Upper Shore Regional Council's been trying to do more press releases to push information out, so. And that is all I have, unless there are any questions about staff reports or other projects.
Okay. Unfinished business, I had the priorities down. You know, when we first started with the priorities, it was kind of my intention, I think, to gain some consensus and also highlight areas that we might want to include on future agendas. So I know you have that as a separate topic, but didn't know if anybody had any thoughts about, I'm jumping ahead though, combining the two, about future agenda items or subjects, areas that you'd like to include. Or anybody who wants to talk about any of the priority areas. But I don't personally, but everything.
I mean, I think a way to move forward with it, because we've been talking about it for a while, would be maybe at the next meeting to discuss what are the top 3 or 5, and then maybe we can do some strategies around those.
Okay.
See if there's anything new to add.
Right. So if everybody, like, what is your, and I'm kind of jumping ahead a little bit here too, but what we've been hearing is housing. You know, we heard it today, we heard it from all of our candidates for the commission. So we're really looking at housing and how can we affect that. So there's a great white paper, haven't read all the way through it yet, Housing as an Economic Development Strategy. I do know the commissioners just approved a grant to the DHCD. I'm going to read that to you because I don't want to get it wrong. The commissioners approved a grant application for funding to support the inaugural county-wide housing inventory as outlined in the 2018 comp plan. The Upper Shore Regional Council has already committed $13,000, and the county's commissioned another $37,000. And this will be all inclusive of all the towns, not just the county areas. So working with planning, housing and zoning, and our grants program, our grants person. I'm not going to get her title right.
Is this a study?
This is a study
And
with
it's to take
data.
account
So
on
what's the title called
housing
again?
units?
I can share the application with the group, so, but it's hold on a second.
What was the title?
Inaugural Countywide Housing Inventory, as outlined in the 2018 comp plan. But we can certainly forward the application to you. We've already got letters of support from 4 towns. We're waiting for the 5th.
Towns in Kent County.
To send with it, as well as the commitment letter from the Upper Shore Regional Council for the $13,000. So I'm very optimistic that we'll be able to get the $35,000 to get that complete. But the application will tell you more of like what we're looking for, income levels, housing cost, and where those gaps are. And then we're also looking for recommendations on how to fill those gaps.
Who would be completing the study?
It would be an outside professional service completing the study.
Who has to be selected?
Correct.
Has
It will
yet
have
to
go-
be selected.
It would have to go through an RFP process.
What's the timeline?
yes.
It'll be like 6 months, 9 months,
I think it's a year.
1 year.
Yeah, I think it's 1 year, Bob, once we get notification that we have the funding. But that's all laid out in the grant application I can share with you guys as well. It'll be complete in the next day or two because it's due on Friday.
And when does the grant get decided?
I don't know the answer to that. It might be in that timeline too. Joanne has been doing the heavy lifting on putting the grant together, so I don't remember a lot of the
So it
details.
could be 6 months before anything gets
I
started.
hope not. I'm hoping they're going to be, that one's a little bit faster because it's a technical assistance grant. It doesn't require matches, shovel-ready. There's a lot of things that typical dirt grants hold up for. This one should be pretty quick.
Why don't you send out the job description for the housing person that we talked about several months ago? Remember there was a job description that was maybe last year? Something like that for
It
the,
was the housing and transportation that was.
was it transportation position? It was combined with transportation?
Correct.
Yeah, but there was a rough job description?
I think there was, yeah, I'll double check.
I don't
that.
think I could find it. Yeah, that might be helpful to start discussion on
Right.
where we could go.
I mean, that might be something that comes out of the study, right?
Yeah.
That you, and I really think we do have to have somebody dedicated to that.
I do too.
There's so many programs and things that have to be managed, but I think this is a great start because then it gives us the data to say why we need this, and we might be able to find some funding for that staff.
Yeah,
hopefully.
right.
Sounds good. Anything else in the priorities, or I guess homework to review again and come next time with?
Yeah,
Top
I mean, I just
25.
feel like that
Yeah.
there's a lot here.
There's a lot.
And if we could kind of pare it down, like,
Yep.
what are the top, like, maybe everybody do their top three.
So
Send me
some
their-
people did, and some people wrote like really long, so
Right.
it's apples and oranges in those
Yeah.
comments too, which makes it a little difficult to.
True.
So maybe each person could go back and redo theirs for the
Yeah,
3
like-
priorities.
Or read through everybody else's, you might say, oh, well, I had that, but I
Right,
really
but I
like
mean,
this, but
everybody should
yeah.
come up with, their
3.
own 3, I think, and follow the
Yeah.
instructions, and then.
we could compile
You
those
can-
together and
right,
say, this
and-
one came up 10 times, let's this be our
Right.
number one.
Sounds
Right.
good. Okay.
So wasn't there a housing, didn't it used to be under economic development and the commissioners put it under planning and zoning?
Well,
What was that?
the housing and transportation coordinator was in the local management board. Got moved to economic and tourism development.
Okay.
Was not funded the next year. We did put in for it to be funded the following year, which was this year, and it was not a funded position. So And it was originally grant funded, correct? It was originally grant funded and the grant ran out.
Is that
correct.
still within economic development? It's been moved to,
So now now that there's no funding for the position,
Right.
housing went back to planning and zoning.
Right.
And transportation, but what really does transportation mean? Because we don't have a ton of public transportation here in Kent County anyway. I mean, I do my best to stay involved, and as I was just talking to the hospital.
What did the housing actually, what did that job that was moved actually encompass? And if we're gonna do housing, shouldn't we ask the commissioners to move all the housing stuff back to this committee?
I don't know the answer to that, Bob.
I don't know
So
either. I was
what
just
was
asking.
the first question was, what was the housing, what was the responsibilities?
Yes.
That was never clearly defined, because I, even after it moved from the local management board to my office, I still didn't understand, like, what is that person supposed to be doing? So that's why the first year, I didn't even ask the commissioners to fund it. Like, give me a year to figure out what it would entail. And after a year, for somebody to do housing, you need a full-time person.
Right.
There's so many meetings, there's so many, and especially with Secretary Day being elected or being appointed, he's very big on housing. There were lots of housing bill packages. And if you don't have somebody to be able to dissect all that and figure out how it can be used for your community, you're kind of at a loss, because I'm looking at it in the middle of everything else. So, and Bill's looking at it at the middle of everything else. So you don't have the capacity to really focus on that housing.
But when we did have a position that was filled, his focus was on transportation, right?
Well, it was supposed to be housing and transportation.
But the bulk of the work that he presented
I
was
can't,
related to
I
transportation.
can't honestly say, Paula, because he was moved to my department halfway through. So I didn't really understand everything he was working on. Didn't have that opportunity to get a grasp.
We need a clear vision.
Right,
Somebody's got to come up with it
Yep.
somehow, and we've got to put it into operation.
yes,
And even though it was moved to planning, there is not a specific person at
good
this time.
point. Yeah, in planning to do it. So, but I
Which
think,
means there's probably not a role that's defined there either,
Right.
correct.
which probably we could all work on. I was just thinking if we're
To
gonna, if we're gonna address housing, then maybe
to your point,
we somehow figure this out.
should housing be in planning and zoning, or should housing be in economic development? Like, where does it really fit,
Well, it
and where
fits
does
in both,
it
so
fit
it's tricky.
best?
Yeah.
So, I mean, that's the big question.
And we
We've
are-
got to have a plan for the housing, but it
Right.
also supports economic development, so.
Right.
It's.
I feel a lot more comfortable after doing it for a year and attending the meetings that I could
Mm-hmm.
to be able to write up a job description than before, when I was just like, here's this person that you're going to supervise. It's a little bit different.
It's crazy, right. You have to have a job description.
Yeah. But after spending a year on it, I can honestly say, like, what I would expect, I know what I would expect of a person who was specifically charged to do housing.
So you can, I don't know where that job description was that you sent out earlier, but if you want to amend that, it doesn't have to be that exact one.
Okay,
If you have other thoughts, now that the question's a little different.
true. Good point. Yep, we can work on that.
That's good. Okay, so moving on to new business. The recommendations to fill vacancies due to expiring terms. I think everyone got the nomination committee's recommendations for the recommendations. Is that,
Yep, should be in the packet, page 17 and 18.
just a reminder that we have to speak about these folks anonymously on the record?
So why, I don't get why one got, like, the last position was fast-tracked and we didn't comment on that one and we were commenting on this one. Those are the few of us who weren't, I don't quite get the process, if it's different for different people or.
Okay, say that one more time so that I understand.
So, Dick Story's position was filled without our board
Correct.
looking at those, and now we're looking at these. I just don't get what the difference is and why we're even doing it or why we didn't do it the
Well-
last time.
A couple of things I can share is that the Economic and Tourism Development Commission is the only commission that has a nominating committee. All of the other ones, just their recommendations get sent to the county commissioner. The director says, this is who we recommend, and they make their appointments based on that, whether they do that or don't do that. In Dick's case, Dick left an unexpired term, which left an opening. During the committee's evaluations, we met on Monday, the 16th, and I did ask the committee members who would be the first choice if the commissioners wanted to get that seat filled immediately. And I don't think there's no, what do I want to say, it was Bob. So Bob was appointed to fill the unexpired term.
I still don't get it, but I don't get why we're bothering with this one then. I mean, why are you asking us our opinion on the second position but not on the first position? Because it's not like we do urgent business that you have to have somebody there. So either we have a process that we do for every nominee, or we make it up as we go along and whatever anybody feels like doing happens. It just doesn't seem, I think we should be consistent and fair to every nominee.
I hear what you're saying, but the commissioners did appoint Bob to fill that position, so further discussion's not necessary at this point.
But it's not up to the commissioners, it's how did the nominating committee, what did the nominating committee have to say about whether or not we should have it to the whole board or not?
Yeah, I mean, I had the same question, just as far as presenting our formal recommendation, having it voted on, and then it going to the commissioners. But I think the commissioners, we serve their pleasure, so they could take it up at any time.
No, I understand that, but, well, I heard different timing issues discussed about this nomination too, so I didn't know what the rush was or why it went to the commissioners before it went to the board. I don't know. And we don't want to discuss commissioner business here, but just pointing out that we should be consistent in our process, that's all I'm saying.
Well, maybe
I
we
agree
need
with
to
you, too.
abolish the commission.
What was that?
Or maybe we need to abolish the committee.
The nominating committee.
And then what?
Just do it the way every other commission and board does it.
Well, I'm not saying that it's bad to have the nominating committee. I mean, you could go straight from the nominating committee to the commissioners. I don't see anything wrong with that. But if you're going to have the nominating committee do that, then don't bring it to us at a meeting here, and then we're supposed to give our opinion on people we haven't met.
I agree with you.
You know, and you've met them and ranked them, so, I mean, unless I know somebody who's personally good or bad, I don't think it's my place to.
That's a good point.
So I'm just trying to have consistency and
No,
fairness.
I agree.
Commissioner Price, please.
I understand your concern, everybody's issues or whatever. This was brought to us in a closed session, so I'm not going to elaborate
Right.
on the.
And it's nothing to do with you, sir. It's just us.
No, I
Okay.
understand. The three commissioners discussed it with the director, and we made a decision that a position should be filled because of the vacancy for obvious reasons to create a full board. We were also considering making another appointment, and sometimes the recommendations come as a recommendation. And all three of the commissioners were all three homegrown. We know a lot of the people throughout the county. So we tried to pick we're sometimes agreeable with the recommendations.
Sure.
And sometimes we're not.
The recommendations, exactly.
So, I mean, it was a decision that was presented to us, and we made a choice.
And I just want to be clear, I have no problem with you making the choice, I have no problem with the commission, I'm just talking about our role in this next nominee, and is this the way we're going to do it? And then why didn't we do it for all of them, or do we not do it? That's all I'm saying, I have nothing, you can pick whoever you want, I get that.
Yeah, and Judy, I see your
But
point.
isn't the
going
nominee
forward.
committee part of you all also, or not?
Say that one more time?
It's a subcommittee.
The nominating
It is
committee is a part of this.
three of us.
Yeah.
But nobody on the commission has a role in.
Not nobody, just not everybody.
So 3 people are on the nominating committee right now, and then the other 3 of us are being asked what we think of the positions that they ranked. But with Mr. Jacobs' position, nomination, we didn't do that. So we're just questioning why the difference in the timing and the process, that's all.
I think it was just to fill, like you said, right, to fill
fill a
a seat
vacancy.
immediately.
Right, but we've had vacancies, around, like when I was nominated for that position 2 years ago, that vacancy was open for months. So, I mean, it just, I don't know how it works.
Yeah, but expired terms, usually the people, they still continue to attend meetings
But this- yeah.
until, usually, so this was
Yeah,
like
I don't
immediate,
think I
you
was-
wouldn't be
yeah,
here,
okay,
is, I
yeah.
think the logic behind it.
Yeah, whatever, okay.
But I would say we could look at the procedure and take that part out if you don't feel comfortable, recommending because you didn't actually interview the people. We could take that step out if that's,
Commissioners.
yeah, if that's the, consensus.
Well, I don't know why you have a
of the
nominating committee if you're going to have it to the whole board and only half of the board gets to interview them and the other, so, it doesn't make any sense. So either the whole board could do the nominating or you send it through your committee, but I don't see why we're being asked at the last minute to comment on your comments.
Okay. It was a previous procedure by other board members, so we can certainly change it and improve it.
What if you could have, it's just
Okay with that.
just a question. Could you have the whole committee be the nominating committee and do it in closed session? Because is that considered
We're not that
personnel?
big.
Yeah, I don't know, but an idea.
Yeah, yeah,
I can check on that.
Interesting.
I agree.
Okay.
So are we up for a vote then, though, on the remaining nominating committee recommendations, or?
So is this for the Sandy's term? Is that what we're talking about now?
Yes, this would be Sandy's term and Charlie's term.
Right, my term expired technically the end of April.
And Paula's term, which ends the end of May.
Which has not ended yet.
Correct, but
Because
we
it's
need to
not the
vote
end
on
of
that
May.
today. We do vote on that today so that we can have.
We vote on what, whether we want to extend them?
No, Paula has expressed not seeking a reappointment due to other commitments.
Oh, what did I miss that? Sorry.
That's okay, that's okay.
Okay.
Do we want to vote on the slate that the nominating committees
So
still go forward with that?
when you say slate, so we pick 2 for the,
No, it's just, if you read the recommendations, there are comments about favorable,
right, I did that.
ranking. And it would be, do you agree with that or not agree with it? We could have discussion, I guess, and, using numbers. And then that would go to the commissioners and they
For,
get to choose.
for Sandy's position.
For Sandy, be it for any
But
of
we
these
could
spots.
reopen it for another round, say, or something, right? Or you want to just keep using these same 3 that are ranked with different, I mean,
That's what's on the table now. I mean, you could.
We've got 3 openings and we've got,
Right.
recommending nominating committee is putting forth 2 names.
Right.
2 more names.
Actually, 3.
Well, 3 names in an order of ranking.
Yeah, so we could talk about number 2. So let's do Sandy's first.
yeah, let me just share with you, because I didn't bring my.
You don't have it. Because he doesn't have one. Okay.
Do you have it written down?
No, I mean, I can tell you that.
Never mind, all I need to know. I didn't have a chance to print it out before I left.
This is, okay, Earl, do you have your?
Yeah.
This is, how do you spell that?
So let's just focus on number 2, to fill Sandy's
Two.
term. Any comments about that or concerns?
No concerns with it.
My only comment is that Sandy was very favorable as this person replacing her, and I think we need representation from Rock Hall, as tourism is, it's one of our bigger areas for tourism, and it's a tourism replacement,
She does fit that.
so I think she fits it.
Yeah.
So do we want to make a motion on each one as we go?
Sure.
I think we should only fill one position today. That's all I feel comfortable doing. I'm sorry, I don't feel comfortable filling 2.
Okay.
And I think we want to rethink maybe the process a little bit, because,
That's fine.
I think there's a strong candidate, and then there's some questions about, I just looked at that one and said, I think I can agree with
I
that
could
from
just
what
tell
I
you that
have.
may change at the commissioners' meeting on the 20th.
That's fine, that's fine.
Okay.
Sure, so do we want a motion to approve candidate number 2? Is that how we want to deal with one at a time?
Yes.
Okay.
Make a motion.
Second?
Second.
Any further discussion? All in favor?
Aye.
Aye.
We want to discuss any others today, or?
I don't feel comfortable. I don't have a clue about this person, and I don't feel like I can make a recommendation. So if the nominating committee decides that's what they want to do, then that's what the nominating committee is going to do. But as a board member, I don't feel comfortable.
So inevitably, is we picking 2 out of the 2, 3, 4,
So
2
far
out of
we're
3 or
picking
3
one.
out of the 3?
Picking one out of the
One
last
right
2.
now.
Just picking one right now.
1 out of
We picked
3.
one.
Well,
Yeah, we picked one already.
So number 3, if we're saying we're not ready to do that one, we don't have to. Number 4, there was a caveat in there that said we are open to seeking alternate candidates or keeping a seat open for a stronger candidate.
Jesus.
For this one?
Number 4.
and that was the feeling of the nominating committee, that we should continue to interview, to solicit and interview
Yep.
additional.
And I don't know who that is either.
So table the others then?
We sure can.
Okay.
Yeah.
Okay.
Okay.
Suits everyone's comfortable with.
The next thing is the Open Meetings Act. I did want to talk about that. The training for the Open Meetings Act was shared on March 3rd. Has anyone had the opportunity to complete that training? Because we always do need to at least have one person, and I know Paula has taken it, and
The
she
Open Trainings Act?
has completed it.
I took it.
You took it? Do you have your certificate, Bob? that
I
you could-
took it, 6 years ago at Winter Mako.
I want to, if you don't mind, I'll send it out again. It's about 15, 20 minutes. So if,
Send it out again.
yeah, if anybody's interested, it doesn't hurt, if you have it for other boards as well, but I'll send it out again.
There should be a record of it somewhere, though, I would expect.
Should be, but I don't know.
Take her longer than
I can
15
check.
minutes to find it.
But it doesn't hurt to, because I've done it about 6 times. Yeah. It's okay. We sent it out on like March 3rd. But I've taken it probably 6 times in my 14 years. It doesn't hurt to take it again because you hear new stuff and the law changes. So it doesn't hurt. And it's not long. So I will send that out. The next thing is I wanted to talk about the August meeting day. Would it be okay with everyone? Mako conference is the 13th through the 15th, and we'd like to do it on August 6th. And there's another good reason to do it that way, if that's okay with everyone else.
My calendar.
August 16th.
6th, right?
6th.
Yeah, I don't know what I'm doing next week.
Then you'll be fine. Fine by me. When you informally,
Is that okay?
yeah, fine with me.
Okay. And the good reason to do that is because you guys had mentioned bringing Dr. McComas in, and she is available on August 16th, or 6th, I keep wanting to say 16th. So August 6th, so that's a good day for her as well. So in June, we've got Scott Boone coming in for information technology. So can we get a motion for that speaker?
Wait, this is for August?
June.
June, Scott.
Sorry,
That's okay.
I'm already ahead of the
Have a
game.
motion to approve Scott?
I think we need a meeting. I think we need a meeting to discuss a lot of things. I mean, we're losing the chair and the vice chair who just ran for the positions. And we have a brand-new person. And we're going to be sort of, starting from scratch. Yeah, I mean, I'm like a little bewildered
I feel
here.
the same way, like, I didn't realize Charlie was the, I guess I didn't read.
I didn't read that carefully. Yeah, I didn't.
And now I looked at it, it's the top of the sheet of paper, I guess
Yeah, and, you guys just ran for office, and now we're going to have 3 new people?
Yeah.
And,
we have to elect a president and all that.
yeah, and it was kind of well, anyhow, I don't want to get into it, but I think we need to sort of have you all, put forward some plans for leaving us in better shape. You just ran for leadership, so I think we should have something, for us
Well, the
as we
next-
go
the-
forward,
the
to
new-
go with the priorities and kind of discuss things and sort of spend the whole meeting on
I
that.
think it's probably the new chair's opportunity to do that.
Yeah, but you guys just ran on it and were elected, and the other person was not elected, so maybe she doesn't want to do that since you all got elected to do it first.
That's her prerogative, right?
Prerogative,
Yeah.
yeah.
Yeah, but you were elected to be leaders. I just thought you might have some guidance and some thoughts from what you've been doing to send us forward instead of just throwing us in the deep end of the swimming pool.
I'm happy to share in the next meeting.
Yeah, that's what I'm saying.
Sure,
Let's spend the
sure.
meeting doing that and trying to get our ship afloat.
Okay, now you asked me to get Scott Boone to come in.
Well,
and
I mean, we
committed to
can, but
June.
I think it's,
You guys
it's
wanna
gonna be hard to
know.
concentrate for me on that, to tell you the truth, when we're sitting here with this situation.
Well, I won't be here at the June meeting because I have a
You're
conflict.
not gonna be at the June meeting.
No, so.
And neither will I.
And neither will I.
All right, well, then maybe we ought to skip it.
Can we move the June meeting, or?
No.
We can't move it?
Do we have to meet monthly?
Well, why can't we move it?
We can move it to another date.
That's what she just said.
In June.
We don't, also, Judy, one thing we don't have control over is when our terms expire.
It's on the
And then,
list.
and then, it's a matter of whether you're gonna get reappointed or not to continue. So, those things are all part of the,
Well, I understand that, but you decided because of too many commitments that you didn't want to continue, both of you, so that's a little different.
Right.
well, we also don't know whether we'd be reappointed.
Well,
That's not something that's,
I just made the decision that
you can make that decision, I understand
yeah,
that,
sure,
because you
sure.
have, but anyhow.
We can try to ask Scott if the 25th would work. Does that work, June? Does the 25th work for everyone?
Two Judys,
Yeah,
25th works.
yeah, I guess,
And I can check with Scott, because I don't know,
okay,
yeah, because he was scheduled for the regular.
okay,
Okay, I'll check.
that makes sense, I'm glad we got the vacancies cleared.
June 25th, possibly, right?
Yeah.
Let me make sure I'm clear on something. So, Charlie, this is not seeking reappointment due to other commitments, I understand that, but then I hear you may not be reappointed. What does that mean? Like,
Well, it's we serve at the pleasure of the commissioner, so
Okay.
it's certainly, if I wanted to seek another term, I could ask,
Okay.
for the committee to nominate me again for consideration by the commissioners. So but it's at the pleasure of the commissioners, right? So
okay.
Well, yeah, we're sure.
could or could not appoint someone.
But if you look at previous history, others have been on for 8 to, more years, if they fill a half a position, whatever. So it's pretty consistently reappointed, but you're right, you can't assume that.
Sure.
Okay.
Anything else?
I heard on my podcast a commercial for Kent County Tourism on 2 of my podcasts, and I was like,
Love it.
I know that.
Yeah, we're out there.
Yeah, but it's random, the podcast, because you don't know what you're gonna, I don't know how the algorithm works to find me on that.
It's targeted.
And they're two different podcasts,
Yeah.
at random, different times of day, and
Yeah, it's targeted, and depending on which one you heard, it might have been.
I heard the same one twice.
Well, depending on what podcast,
Yeah.
or whatever you want, it might have also been, do you have some that are set to target outdoor enthusiasts or things like that? So I feel like that might have been
Maybe.
why you got it.
Yeah, that was cool, that was really fun, because I hear Crawford County, PA a lot,
Okay.
and they have an app.
Oh, yeah,
Motion to adjourn?
Well, let's get some clarity. So
Okay.
next meeting is June 25th?
I think you were checking to see if the speaker could
Yeah,
fit at 10.
yeah, that's true. I need to check and make sure that Scott is okay to do that. If Scott's not okay to do that, do you just want to have a regular meeting?
Yeah,
Yeah, there'll only
you don't
be
have to
30
have a meeting, yeah, you have to have a meeting once a month according
You
to
don't,
rules.
yeah, you don't have to.
And you don't have to have a
Confirm that
speaker.
We will meet next,
Okay,
June
so
25th.
June 25th,
Hopefully Scott
and then
can
we'll,
attend.
yep.
Okay.
And do
Sounds
we have a
good.
president?
Now, the next meeting, Charlie will be here. He'll
If
be
we
here.
move to
No,
June
we can move the
25th.
date.
You'll be here?
I could be here.
Yeah, that's good.
Perfect. Okay.
Yeah.
Coming, Paula? 25th.
Oh, yeah, we also need a motion to move the August meeting. Sorry, too many people talking. I
Okay.
get confused.
Motion to
I'm
move
like
the
a squirrel.
August meeting to August 6th.
August 6th, perfect.
Motion.
Make a motion.
Second. Approved.
And about July.
Aye.
Aye.
Motion to adjourn.
Thank you.
Yes.
Mr. Commissioner.
Just real quick, public comment section.
Oh, you're right. We've skipped that by accident.
I would like to thank all of you for serving on this commission and on this board, and I certainly appreciate everything that you do. A special thank you to Charlie and Paula for their service.
That's why he's here.
I'm looking forward to what the commission comes up in the future with as far as economic development and especially housing. I would like to report, if you haven't been told, that this senior housing project up in Millington is moving forward very well. We met with Frank Hodges yesterday, gave him a letter of intent. Is that Quinn so much?
Yeah, because that was on your
It's good.
Those are-
Okay. To support him with some funding if in fact he had to come to us. We don't think he's gonna have to, but the letter of intent kept the project moving. We also have the 301 corridor project underway. We are probably about 90 to 95% completed on the design of the wastewater treatment plant that the county is very excited about. The village of Kennedyville, Phase 2, is supposed to be going out for bid tomorrow. And we're hoping that we have some interested folks right now. We're hoping to move that forward in the very near future as well. There are some other housing initiatives that I'm not at liberty to really talk about at this point in time in the county, which I think will benefit and help stabilize the revenue sources that the county is going to need for future years. I am very guarded, along with my two colleagues, about preserving our agricultural way of life here. We all like the open space. We all appreciate what the agriculture community does. We have guidance from the comprehensive plan, along with the Great Planning Commission, to direct some of this growth. Yes, I do want to see some growth business-wise, but I don't want us to ever look like Middletown. But I think the housing is going to encourage economic development in the business community. That's my hope. And that's the direction or the vision that the commissioners, or at least this commissioner, has at this point in time. And I was glad to hear about the hospital, and glad to hear that they have a pediatric initiative, maybe just over the water. I think that's all a plus. And again, Charlie, thank you. Paula, thank you.
Thank you. Any other comments? Sorry. Okay.
Can I just say something? Can I say something to the commissioner? I think, I'm so excited about the possibility of getting more housing, but I also don't want the new housing that may be built to be taken over by people that are running them as Airbnbs or second or third houses. And I don't know what we can do to stop that, but we need to pay attention to that.
What I am hoping for, Judy, is that we encourage developers to come in, and again, I don't know what affordable housing even is nowadays, but I want to see our schools thrive more. I want to see the enrollment go up. I want to see the workforce stay here in Kent County and work and live here. And we're going to have to build the type of housing. That's why this grant that Jamie brought to us the other day, I'm a little excited about that, a lot excited actually, because I think it's going to give us an idea of the type of housing that this county needs to sustain itself. And to encourage younger people. Nothing against us old people. You're not old, you're not old, you're not old.
Don't start.
I'm going to share something
The
else.
rest of us have got some gray hair. And, you know, we need to make sure that there's accommodations for everybody here within reason and still protect our Kent County way of life. That's extremely important.
Rock Hall has changed their zoning of that property behind the Walgreens to it's mixed use, so housing and commercial on the bottom, but they are putting in a restriction, no Airbnbs, no short-term rentals. And I think that's a model that other communities could do, whether it's through zoning or whether it's through homeowners associations.
So I'm on the Rockall Economic Board, and we did a lot of research on doing homeowner associations, especially on the property Jamie just spoke about, where a homeowner association can limit what's allowed in that community. You can also, there used to be state grants where if somebody joined the fire department and then they lived in that association, you could limit houses for people who served on, like for the ambulance crew or the fire. So I know they used to have those, and that's what we were researching down there.
Some government-like incentive for, you know, our fire companies are actually struggling throughout the county. They do a great job, but volunteerism, the young folks just aren't volunteering. So maybe as we look at some of the stuff when it's being brought into us and presented, we can try to, and I don't know the legal process of it without asking Tom Yeager or asking for some type of legal review, but require no bed and breakfasts.
Yeah.
In these potential housing developments.
My understanding is you can do it through zoning and/or the homeowners association. So there's two ways to do it.
And maybe providing some type of incentive if you live in the community, maybe behind Rock Hall, behind Walgreens, or up in Galena, where they're talking about doing something across from that firehouse. If you volunteer a certain number of hours per year, you may get a real estate tax.
Yeah, I think you can get loans too through that, or at least you used to be able to. So.
They actually provide a small retirement, I believe, if you do so many years for so many years.
And they get income tax credits, but as far as I know, they don't get any property tax credits. I believe Queen Anne's County does property tax credits for first responders, but I'll have to look more into that.
But I'm excited about some of the things I know that are going on. We're trying to get the infrastructure in place up north, and the infrastructure is already in place in the other areas that I can't divulge.
Great, thank you.
Stay tuned. All right, I gotta go.
Adjourn?
We already adjourned.
Again?
Yeah, again.
We already adjourned.
I can't second. Well, I could have given you right after all.